webinar of the Nails Fellowship. And today we'll be discussing about the infection. And first speaker will be Dr. Rajendra Chandak from Nagpur. He will be talking about how to manage acute infection following nailing. Over to you, Rajendra.
Start my share screen. Sir, able to see my screen?
Yes, very much.
Yes, sir. Yes, sir. It's visible.
Visible, no? Okay,
Yes.
just give me 2 moments. Can see the screen now?
Yeah. Yes.
Yes.
Go ahead.
Yeah. So, I'll be speaking on surgical site infection following a fracture fixation. Most commonly nowadays we would do with the nail, but infection can also happen with the plate, and usually the principles involved are almost similar in management. So, this was a patient who came with a nailing procedure done, and from the previous wound and from the nailing site as well as all the interlocking site, he had a free flowing pus, and it was a very ghastly infection. He came within around 21 days, and we were able to manage him with, of course, all the principles of infection management along with uh, antibiotic elution, along with maintaining the nail in situ, what we call as a dire procedure. Most commonly used treatment principle after a established infection, which is actually a chronic infection nowadays we will be using in a nail, is an antibiotic coated rod. However, when we use uh, when we want to manage an acute infection after a nailing procedure, two main principles we use. One, debridement, antimicrobial therapy, and implant retention, what we call as a dire procedure. And if infection is not getting control, or if patient comes late or with comorbid condition, then debridement, implant removal occasionally also is required, or a exchangeal would be required. And the infection control when we achieve, we have two things in mind. Either we are able to eradicate infection, which is a rare possibility, but infection suppression and infection control is actually what is achieved by most of the measures we undertake. So when we are managing an infection after nailing, if the fracture usually would be unhealed, then we would be using in acute phase the implant retention if it is well fixed nail, a nicely done nail, a nail which is giving good stability. Then we try to maintain the nail, same internal fixation device, and we try to control infection. And if this happens over a period of time beyond, say, 6 to 12 weeks, or once it is established and bone lysis has occurred, then it would be removal of the implant, then antibiotic coated nail, and in second phase, bone grafting and fixation, etc. If the infection happens after a healed fracture, then of course, removal of the implant and other measures are required. This is the study from the paper where if we are maintaining the implant and we are trying to control infection, the probability of success, if it is less than 3 weeks, less than 6 weeks, less than 16 weeks, and when the time zone progresses from 3 to 10 weeks, these are the percentages of success of infection control. So earlier we do it, if it is our own case, we should take decision early so that the same implant can be retained and a proper infection control can be achieved. So the success rate would be 90% for implant retention in acute and early phase, which is actually a very good control. Beyond 3 to 6 weeks, then the chances would go on declining. So take action as early as possible. What would be the factors which would make decision making difference? So that would be, sorry, the time interval, as we discussed, that is most important. Then the osteosynthetic construct, whether it is a stable implant, previous nailing has been done to the satisfaction of surgeon, whether the fracture reduction is optimum or not, whether sufficient debridement is possible, whether severity of infection is a possibility where we can manage with dire procedure. If it is free-flowing infection with all-round sepsis and all the planes are involved, in that situation, it would be better to remove implant and then to go ahead with external fixation. If it is an articular infection, post-operative in a metaphyseal zone, usually we would retain the implant, get the infection control, and also the condition of soft tissue makes a difference. And the most important thing would be the host physiology, whether it is type A, type B, or type C host. So, three important things: fracture location, soft tissue envelope, and the host physiology. Like this patient came after a tibial plate fixation, actually it was. And if these tissues have gone, the soft tissue envelope is poor, then in this case, rather than implant retention, we will be going ahead with alternative procedure covering the soft tissue, etc. When we control infection, four most important thing is, apart from debridement, would be IV antibiotic therapy if you have isolated the bug, and local antibiotic elution, for which we use multiple things which can be used. So the most common we use is the stimulant or antibiotic cement elution. This is a very interesting slide which gives us the amount of bacterial control when we use various measures to control the infection. In yester era, like in 70s and 80s, whenever there used to be an infection after a surgical procedure, it was all open the wound, open few stitches, and then come from wet dressings to dry dressings. Then when we use a standard negative pressure wound therapy, then if we use silver dressings along with negative pressure wound therapy, then augmented negative pressure wound therapy with antibiotic coated beads or a cement, antibiotic bead pouch with negative pressure wound therapy using a sponge. These sponges are very special with silver elution. So we get highest with this. Now this is our endeavor to go on decreasing the bacterial load and giving more antibiotic elution. This is in what nutshell is the answer to a acute infection. So the advances like antibiotic pouches, vacuum dressing, silver impregnated dressing, and the most important thing remains is a debridement, thorough wash and lavage. As acute is the procedure after nailing infection, say if you are able to do it on day 5 or day 6, most important thing would be acute good lavage and debridement of all necrotic tissue. Why we use negative pressure wound therapy in many of these situations is there are two important things, the economics and the ergonomics. It gives a quicker cover, reduced hospital stay, and the antibiotic requirement also goes down. The attendance and our constant supervision to the patient also is well manageable. The soakage and cross-contamination in ward decreases, and as the pain decreases, the mobility of patient also improves. So whenever there is an acute infection, it doesn't matter even if you completely open up the wound, completely the whole wound should be, not only a small opening should be made to have a good antibiotic elution also to remove dead tissue, to wash and lavage, so that we also are able to take away most of the biofilm associated with the infection. In acute phase, When do you use antibiotic coated nail? If the construct is unstable and if it is not providing stability, then I would prefer to go ahead with the antibiotic coated nail, for which we would be listening to a wonderful talk from Shiva sir himself. There are, for antibiotic coated nail, if you want to use, again, we will be listening this in Shiva sir's lecture, special nail, special knurled nailing, etc. So I will not discuss much in detail. If we have by any chance used a plate or a plate and a nail construct, then complete debridement. In that situation, I would remove all necrotic tissue, etc. And then the plate I'll be providing with an antibiotic elution with a cement covering and vancomycin around 3 to 4 grams and colistin if the bug is not isolated. If the bug is isolated, then according to the culture and sensitivity report. When to operate? So whenever there is acute infection after nailing, so as early as possible clinical suspicion, of course, pay attention to obtaining culture, deep cultures, also get them cultured into Bactec bottles so that we get a good antibiotic isolation. So these were the cases when they come acutely with infection. Say they may throw a sinus or they may show abscess. This patient showed a pustule near the interlocking nails, and this should be intervened as early as possible. Rather than just starting as antibiotic coverage, we should open them up, get the bacteria cultured, and then do a Dare procedure. So open the wound completely, do wash, lavage, and and a complete thorough debridement. The debridement has to be as thorough as we all preach every time. So this was a patient who came after a nailing procedure and had free flowing pus, so much so a full bowl of pus and was flowing freely. And also had a dead sequestrum inside. So we had to debride the bone also, get negative pressure wound therapy. So these were the successive X-rays where we used elution also in around, this was around 6 weeks post-operatively. So these were the antibiotic cylinders with cement, so which could lead to a good elution of antibiotic. And even that uh, suppurative condition, a very free-flowing pus, this wound also responded to a good debridement, antibiotic elution, and stability at the fracture site. All the infections what we face in orthopedics usually are biofilm related, and we must take all the measure to remove the biofilm from the medullary cavity. So the whole medullary cavity has to be curated out thoroughly. When there is a failure to achieve infection, usually it would need a second debridement, or you have to go with antibiotic elution and a second debridement. So this has to be thoroughly curated out. Whatever bone debris, dead fragments, many times the fragments have lost their vascularity, and if they are flowing into pus or slough or granulation tissue, we must all remove them, wash as thoroughly as possible. So here we see a patient who was post-operative around 3 months down the line, and then we had done a complete debridement, removed all the necrotic tissue. For wash lavage, I like to use this Y connection, and this is a very useful tool where we can put this onto suction and you can wash the medullary cavity with saline and peroxide. Usually, I like to use peroxide many times. The only thing we have to take care is we do not pressurize the medullary cavity so that a chance of a air embolism is minimized because of the air bubbling inside out. Otherwise, I have used it quite commonly and it is effective. Peroxide is the best material to remove the biofilm. We also have to take care of curating all those small interlocking holes, because the biofilm also goes and buries into the screw holes. So we must take effort to curate it out. The whole medullary cavity, if we are removing the nail, has to be cleaned out. This patient came just 15 days after the procedure. This was an open nailing which was done for him. And then with such a massive amount of infection, it was, I thought, retaining the nail is not good. So we change him to antibiotic coated nail, and that patient also over a period of time healed very well. So this is a patient who had an infected nail. I'll stop here with this discussion and have some interactive discussion. I'll stop at this moment. This is a patient who has come with nailing and infection. So this is where we would discuss the case.
Anybody wants to answer that? Rupesh, Nandkishore.
6 weeks down the line, fixation was done with the intramedullary nail femur. Patient has
There was, good evening, sir. There is a gap at the fracture site,
yes,
and there was a loosening of the distal interlocking bolt.
yes. Agreed, totally agreed. The good findings you have shown.
You can share that X-ray, Rajendra.
Yeah, I'll share it again.
Yeah. Yes.
Yes. Able to see the X-ray?
Yeah. Right.
So it seems to be a chronic infection with the lysis at the fracture ends.
Yes. So
So
this
we
was,
are.
yeah. So this was, I think around 8 weeks down the line he had come. Fine.
So we have to better remove the nail.
Right. Agreed. Totally agreed. What? So if the implant is not stable and you feel that it is not holding the fracture properly, it is always better to go ahead with removing the implant and providing stability with a antibiotic coated nail. Yes.
Yes.
Okay, you can proceed what was done.
So this was his original.
Anybody wants to take what, how will you proceed?
Yeah. So what now the question from my side would be, of course, I am showing his previous X-rays also. This was the X-ray before treatment. And what could have been done better? Of course, here he has an infection. For stability, anything anyone would like to suggest? Or for infection, anyone would like to suggest?
Distal femoral nail, sir. Multi-log distal femoral nail should have been done.
And in that case, if patient had,
Retrograde.
yes, retrograde distal femur nail was a very wonderful choice in this page. But in case he gets infection with a distal femur nail, now how would you like to manage? That is also a possibility. Acute flare-up of infection after a distal femur nail. So in that case, would you like to tackle it with orthotomy, removal of implant, or go ahead with maintaining the implant? This would be the questions in mind.
Yeah, removal of the nail, freshening of the fracture site
Right,
with a cement spacer,
right.
and would rather apply a lateral locking plate, a long lateral locking plate.
I think that's perfect. So what you are describing is good debridement, good physical stability or good mechanical stability, and providing with a plate from lateral side and good antibiotic elution. I think that is perfect. Absolutely perfect. Yeah. Any.
So we have to keep antibiotic cement spacer at the fracture site.
Yeah, we have to keep antibiotic cement spacer, both intramedullary, it would be with the nail, and at the fracture site also, if you use antibiotic spacer, that is good. So this was how the patient presented with discharging sinus. And this is the intraoperative photographs where we see a pus also coming out at the fracture site from the nail. So that was removed. And this is how we poured the antibiotic nail. So this was simple K nail. I like to use K nail for femur. And then we put cement 20 grams or 40 gram for femur. Usually 40 gram is better. For TBI 20 gram. Antibiotic vancomycin I use commonly. And a suspicion of a gram negative, then we use either colistin or other aminoglycosides. So this is the usual combination. And then we apply it on all the side and fill it in the slot of K nail and then roll it. And if we roll it and make it smooth, then extraction is better. And this is the fracture site. So this was the antibiotic coated nail. And these are two hemicylinders of cement elution, which gives good elution at the fracture site, which is also infected. And these two cylinders can be on mediolateral or anterior posterior, whatever side. and we can make it contiguous also with a line dividing in between, so that when taking it out, it becomes easier. And that patient healed wonderfully. So
So
this
can
was,
we,
yeah, this is the final construct. After the antibiotic coated nail, infection settled down, and then we exchange at 6 weeks with antibiotic with a nailing procedure provided from the proximal site itself. This is the graft which has been put at the fracture site, and that patient healed over a period of time nicely. So I'll stop share here.
what graft is kept here, sir? It's a
So
fibrillar
this,
graft.
no, this
Tricortical graft.
yeah, tricortical. Actually, what I like to take is this is how the patient healed. So sorry, I'll just stop share. So it's graft. I like to take it out for all non-union from the inner table of iliac crest. So that is a sort of the inner table, one cortical side, and then cancellous pieces. The inner table we put onto the side of bone at fracture site, and then just keep it in position with two small 3.5 mm screws. This is what usually my grafting procedure would be for a distal femur. Yeah.
On both the sides, medially and laterally, we have to keep, or on one side is an.
One side is good enough because that table is good enough for one side only. And on the other side, usually on the medial side, that is the mechanical axis bearing of femur is the better side for grafting, where I would put a lot of cancellous medially. So most of the cancellous grafts are medially, and laterally it is that small plate which we take out from the inner crest of ilium. Yeah. Any other question?
Any questions? Sangeet, any question to
Yeah.
Rajendra?
Sir,
When we
may
have to,
Yeah,
hello.
please go ahead.
Sir, I am skeptical about the role of this hydrogen peroxide.
Yeah.
Is it many surgeons avoid to put the hydrogen peroxide? They say if there is a necrosed tissue, the hydrogen peroxide works on the necrosed tissue only, and it also devascularize the tissue. This angiogenesis, it prevents the angiogenesis. Is it okay, or
So
what you want to
most,
say
yeah.
about
So
that?
my answer is what you say. Concern is absolutely all right, but one thing is a practical experience. All of us, possibly in our government institutes and hospitals, have used extensively hydrogen peroxide. I also studied the literature. There is a recent reference also that hydrogen peroxide and betadine combination is the best thing for biofilm destruction. Two or three important principles with hydrogen peroxide. Number one, you are not medullary cavity insufflating the hydrogen peroxide in a closed chamber. So when you remove the nail, you are debrided, there is infection. You irrigate that area with peroxide betadine combination. The whole surface is kept open. So there is no chance that this air embolus, which is an occasional, very rare thing quoted in literature, that it may lead to formation of a air embolism because of the peroxide nascent oxygen which is liberated. Number two, you are not non-monitoring the patient. The patient is under monitoring. And third, whether it kills the normal tissue. We use so many times on normal tissue that I don't think the normal tissue goes and gets necrotic. What hydrogen peroxide does is it liberates nascent oxygen. So it is not tissue toxic in the percentage we use. We use hydrogen peroxide only two strengths, 3% and 6%. These are the only two strengths available. If you are using 100% H2O2, which is not at all available for clinical use, then only it could be tissue toxic. And if you pour it on a normal tissue, we are not pouring on a nerve, or we are not pouring on a deeper structure like vascular structure. We are into a subcutaneous plane most of the time. So we can use it, and we have used it. Yeah. But concern
And the
is well understood. Yes.
and sir,
Actually,
please please explain the amount of antibiotic, like vancomycin, how much?
destroys the bacteria.
Sangeet, I think we are listening your voice in a.
Yeah, his network is probably not correct.
If you can close your video and then
No,
speak, Sangeet.
Dr. Rahul was speaking about it. I
Yes,
stopped
sir.
in between. Am I audible?
Okay.
Okay.
Yeah,
Now you're
yes,
audible. Now
Regarding
you're
perfect.
the hydrogen peroxide, okay. See, not only it kills the bacteria, but it also kills the normal tissue, healthy cells. Okay.
Mhm.
And uh, in severely compound, in badly contaminated, it is all right. But for a normal wash, it should not be used
Yes.
because
Totally agree.
it kills the healthy tissue also.
Yeah.
And not only
So
Sangeet
totally
is
agreed.
not.
What Sangeet says is totally agreed. We are not using it, say, for any open reduction, internal fixation. We are not washing that wound with a peroxide.
Yeah.
Sure.
And moreover, we dilute that also with normal saline. We
Normal.
don't use directly.
Yeah.
Yeah.
Sir,
Yeah,
Sir,
that
please,
point well
please,
taken up, Sangeet. Well clarified that we are not using for routine wash of any routine wound. That is not done. And nobody does it. So
and
routine
sir,
wash is
please
only for.
tell the amount of, uh, may I? Sir, please tell the amount of antibiotics in 40 grams, how much we should put. This is always
Any
confusing
antibiotic
for me,
simple thumb
how
rule
much.
is maximum 4 vials. Simple.
Yes.
Yeah.
Simple thumb rule.
Simple thumb rule.
So vancomycin for 40 grams, I use 4 grams of vancomycin. And colistin is limited only to 2 because of the concern for renal safety. So if you are using colistin, only 2. If you are using gentamicin powder, it is 500, that is half gram, that is 500 milligram. If you are using tobramycin, it is 2.5 grams. If you are using amikacin, it is 1 gram.
In 40 milligram,
In
40
40
gram,
milligram, 40 milligram of cement powder. Yes.
40 gram.
Yeah.
Thank you, sir. Thank you very much.
Thank you so much.
Sir,
Sir,
I have a
when do you
question, sir.
operate when do you go ahead with the second surgery, sir?
Yeah, go ahead one by one. Vivek, you can go ahead.
Yes. When do you go ahead with the second surgery, sir? Final surgery, grafting
So,
and fixation.
yeah. So by and large, routinely the antibiotic elution graft is picking up at around 48 hours to 7 days, and then it declines at around 3 weeks to 6 weeks. So maximum is at 6 weeks. Ideal would be between 3 to 4 weeks. But by that time, the patients coming back becomes a bit difficult because they've spent a lot of money just for the first stage. So most of the patient come back at around 6 weeks. So definitive fixation at 6 weeks. And if everything is fine, CRP, ES are coming down to more toward baseline, then grafting at the same sitting itself. Okay.
Sir, can
Okay,
we
sir.
make the patient walk after antibiotic coated nails?
You must, because the tissue healing responses increase when you start the weight bearing stimulus to the limb. Also, the profound osteopenia which is set in because of infection also can be managed. And your antibiotic coated rod has to be snug fitting, number one. Number two, if at all there is an instability at fracture site, I would also additionally add a small plate and coat it with bone cement. You must make him walk.
Yes. Okay,
Right,
Rajendra.
sir. Sir, I
Thank
have one
you.
more question. Sir, I have
Yes.
one more question. Sir, if the soft tissue coverage is poor and because of that we cannot put the antibiotic coated nails, so the external fixator is an option then left, sir, or any other option can be done after the
Obviously,
implant
obviously.
removal?
Yeah. So these are our routine choices in orthopedics. If say you have a large soft tissue loss, so consider providing along with the external fixator or LRS, also think of providing a good soft tissue cover in form of a flap or tissue transfer technique, whatever you want to do. That is a must
Right,
because
sir.
whenever you want to control infection, remember 5 things are very important. Number one is good debridement. Number one is debridement, good debridement, debridement. Number two is stability at fracture site. Number three is elimination of dead space. Number four is IV antibiotic therapy. Number 5 is eluting of antibiotic. Now you also have 2 or 3 additional things, that is negative pressure wound therapy and a soft tissue good envelope is important. So if these things are ensured, almost always infection would respond favorably.
Right, sir. And sir, in last of your cases, you put the bone graft also into the fracture site. So that was after the antibiotic cement
Yes,
usage in the second
yes,
surgery, sir?
in the second
Okay,
surgery.
sir.
So first
Right.
is debridement, good stability with antibiotic coated nail, making patient walk. ESR, CRP climb down. Patient is feeling better. He is eating well. So phase of catabolism is gone. Now the anabolic phase starts, and that is the right time to intervene. Okay, and then
Right.
graft. Fine.
Thank you,
The,
sir.
the, the nail for antibiotic coated nail, only K nail is used, or we can use that regular interlocking nail also.
What my observation is, the canal is advantageous in two things. One, there is a slot in the canal, so you get a good amount of antibiotic coating and remaining there inside. The debonding is less also in canal. And third is, if you are using a round nail, then these round nails are not available in 7 or 8 mm. They are available maybe beyond 9. The amount of antibiotic coating also diminishes with the interlocking nail. So my preference is towards K nail, but Shiva sir has a large series where he has used a specially made interlocking nail, which he will be presenting in the last. Okay.
Okay, sir.
Rajendra, thank you very much. Don't go away
Yes, sir.
because we are discussing infection. Your
Yeah,
vast
I'm here.
experience is going to help us.
Yeah.
And after Sangeet Gawhale's talk, we'll have some more discussion.
Yes, sir.
Over to you, Sangeet, for your talk on antibiotic coated nail.
Sir, one question, sir.
Yes, go ahead.
Sir, many times we see the CRP level does not comes to the baseline. Even though clinically we feel the infection has subsided or infection is no more, but CRP level does not come to the baseline.
Yeah. So
And we cannot rely completely on the ESR. That is an inflammatory marker. So is there any range for the CRP, or what we think for that?
So the clinical judgment of surgeon is the most important thing. You palpate at the fracture site, the soft tissue feel is good, there is no tenderness, patient is feeling better, and now the CRP from initial of 100 has now come down to 10 or 8. I will feel I am ready to go ahead with in that case. But if the patient's feel is also not good and CRP remains somewhere beyond 40, 50, patient is still having pain, then in that case, I'll go ahead with second debridement, control it further, and then proceed with the final treatment. So it's a judgment.
Sir, have you ever gone through that your first procedure, this antibiotic nail or that whatsoever you can do, you have done, and even though after 6 weeks, even after the 6 weeks, the infection has not subsided,
Yes.
and in that condition, what you have done?
Yeah, it happened not only once, many times. And in that case, I always get a consent of patient that antibiotic and a debridement procedure is not one stage. It could extend to 2 or 3 stage also till our satisfaction. So in that case, again, if you again analyze those patients where infection is not controlled, again think on those 5 things. Most commonly, it is not removal of a dead segment of bone, one, or not debriding the antibiotic membrane which is there in the whole cavity of femur or tibia. You have not curated enough, or there is a focus of infection somewhere else, or patient's comorbid condition is not controlled. So there has to be some reason, or the antibiotic you chose was not proper. So these 4 things I will focus. I have debrided again and then but succeeded.
Sir, are you getting the K nail
The
still?
antibiotic sorry.
Sir,
Yes,
are
sir,
you
please.
getting the K nail still? Is it available?
Yeah, canals are available, no problem. You just have to ask for them. Canal is a very advantageous situation.
Okay, sir, but
Use of
still
a
no, it's not commonly used nowadays. Are we able to get it?
I think so. We in our era we used canals extensively. We had a good experience with using them. But if you want, you can also use antibiotic, the interlocking nail. The problem why I don't use, I have access to interlocking nails as well. Why I don't use it is because in K nails you have a inner bonding of cement inside the K nail, which doesn't usually debond. This is what my observation is. I think Sangeet also would put his opinion
Yeah.
on that.
Anyway, we are talking about that in the next talk. Yes,
Okay.
Sangeet is talking about that. Yeah. Please, over to you, Sangeet.
चलो मैं ज्वाइन हो गया सर.
Good evening,
Okay, you are
Tarji.
the last person. We
Good
will
evening, sir.
cover infection today first. Yeah.
नहीं नहीं ऐसा कोई बात नहीं.
Yes. Okay,
So,
Sangeet.
yeah.
Yeah.
Yeah,
Am
we
I
can see your
visible?
screen. Yes, yes, we can see your screen.
Your desktop we can see.
And now?
Now you have done actually painting of Dr. Shiva sir's image.
Yeah, that's what.
Come,
Since talking, my image.
come again.
Yeah, you are shared the desktop, not the presentation.
Share screen.
गवाले सर तुम ऐसे गलतियां मत करते जाओ यार.
Share window or share screen?
No, you have to share screen.
Now?
No, yeah, to come. Share screen, then go to your topic and select that. Yes, now we can see you are sharing the screen. Then you have to select your presentation now, Sangeet.
Double click to enter full screen mode.
Yeah.
आज क्या हो रहा है मालूम नहीं.
बारिश आ रही
No, no, no.
नहीं. Okay, now?
No. We can
You
see
have-
Gadegone
you-
only. Yeah,
you
now
have-
you open your presentation.
I have opened it.
Yeah.
I can
Then
see
we
it
can
on
see only Gadegone.
ये क्या
We
हो
can
रहा
see your Zoom screen.
है? मैं क्या क्यों मैं दिख रहा हूँ?
Yes, yes. अभी मैं बात करें तो मैं ही दिखूंगा.
अभी लाइट बंद करूंगा थोड़ी देर.
So
By
why
that
this
time,
is
any question is there, we can take up that question also.
चांडक साहब हो गया क्या आपका लेक्चर?
हाँ, चंडक सर का हो गया.
Okay, sir.
अभी गवाले सर का है, उसके बाद मेरा है, उसके बाद आपका है. We'll finish infection first. then
Chandak
we'll-
sir, one
Yeah.
question I have got, sir.
Yeah,
How
go ahead.
long do you give IV antibiotic therapy?
The recommendation is for 3 to 6 weeks, but I usually give for 15 days only. And then if this antibiotic spectrum allows oral, then for 6 weeks. If it doesn't allow, I stop at 15 days.
Okay, sir. Thank you.
After 2 weeks,
So do you do serial CRP, sir,
So on day
after the
one,
infection?
yeah, obviously on day one when we take up the case, then he gets discharged. When he comes for follow-up at around 3 to 6
Yeah,
weeks
now
when
we
we
have
are
got
contemplating the next
Sangeet.
surgery. Yeah, now we can see your screen on. Again, same thing is happening, Sangeet.
same thing is happening.
Yeah, same thing is happening. Can
sir,
you
after 2 weeks of IV antibiotics, we have to put oral antibiotics or we need not put it?
No, ideally we must continue for 6 weeks. But if there is say Klebsiella where there is no oral drug, so what else we can do? That is a big problem. Or occasionally when it is mandatory, I will put a port to the patient or a central line, etc., and then continue IV antibiotics
For 6 weeks, sir?
for 6 weeks. In difficult cases, ideal is 6 weeks. But in practice, many times 2 to 3 weeks, if everything is fine, I would stop.
Similar to
Now-
osteomyelitis, we have to give antibiotics.
Yes, similar to osteomyelitis.
Yeah, now we can see Sangeet.
Now it is fine, Sangeet.
It's visible, huh?
Yes,
Yeah.
Okay. Now, the first part was how to handle the infection, acute infections, and what is the emergency management required till debridement and all that. Once the infection is established, now what is the role of antibiotic coated nail? In last 2 decades, there has been, if there is a new thing which has come up, that is antibiotic coated nail. They are available commercially. This is the ready-made antibiotic coated nails available. I come Singapore or Hong Kong, but didn't had enough response. So the sale part was not adequate. So that is why it is not commercially readily available. So they release a high concentration of
Sangeet,
antibiotic
you can
locally.
switch off your video because your voice is breaking. You can close your video. Just
Okay.
video. Yeah.
I don't know how to close that.
Left side on the Zoom, there is audio and video. You just click on that video. It will get switched off.
Now?
No.
Now?
I have stopped the video anyway.
Okay,
Yeah.
fantastic. So
Okay.
you don't want to see my face.
No,
Now,
because that is
yeah,
taking your
I
bandwidth.
understand.
Yeah,
I
I know.
understand. So fracture-related infection, it remains a common and potentially devastating complication after osteosynthesis. My audio and video is visible, audible and visible.
Yes, audio is quite good, better now.
Okay. And in
The
open
screen is
fracture,
seen. Yeah.
okay. And in open fracture, the risk is higher. There is limited scientific evidence for universally applicable treatment and recommendations for fracture related infections like this. And that is because of the bacterial drug resistance, the bacterial biofilm formation, and the long duration of treatment required in such cases. And also the prognosis is uncertain. And to top off to it, also that there are defects which are left behind following infection. Like in this case, there is a huge medial defect and a discharging wound that leads to additional patient suffering, and the treatment prolongs for quite a long time. Traditional treatment, when we had infection, the disadvantage was usually it did not give enough stability. I'm talking about the fixator when they were used to control the infection, especially for large segmental bone defects, which has an adverse effect for infection control and bone union. External fixation has a risk of pin track infection additional to the existing infection, and the treatment always required multiple surgeries to get an end result. There is a lack of sufficient medullary occupancy effects, which may lead to a dead cavity formation inside the medullary canal, and that is the reason the infection were never controlled when the fixators were used. And to some extent, this method did not allow functional exercises. That means patient could not use the arm or the lower limb effectively during the treatment. So the traditional treatment, this was in about 44 or 5 decades back. On a thin guide wire, beads were used uh, around the infected area, and then serial debridement was done, but the infection persisted in spite of adding the beads, and at that time only gentamicin beads were available. Subsequently, then we went on adding other additional antibiotics, but we never address the intramedullary part of the infection, or we never used to look at the necrosis, which was an end result of inadequate surgery, or the dead bone was never uh, lion-heartedly excised so that the infection is cleared and patient had a healthy wound. So this dead bone was experimented with multiple drill holes, removing only part of it. Now, with so many options available, we are aggressively treating that by excising it entirely. And then we do the dead space management either with a cement, antibiotic cement, where which is used for local delivery of the antibiotics. And once the infection is controlled, following a debridement, we remove it, and then the defect and the non-union is treated with a plate here in this situation and a graft to get a result like this. So antibiotic cement nail, they came in vogue in 1998. And this was contrary to the concept that placing a new implant at the site of active infection to provide osseous stability, which has been our teaching for decades. But the aim was to achieve a good infection control and to prevent formation of new bacterial biofilm. So the antibiotic cement nail basically were two or three types. The one which Dr. Chandak sir has described, this is I think the one on the left is the Yogeshwar nail, which they have withdrawn. I think this was designed by Dr. Shiva, which has multiple serrations to have a good bonding of the cement over the nail, and the other one which was custom made on the table inside the operation theater. So bone cement coated nails can give relatively rigid stability, which is essential for control of infection and reconstruction of the bone defects. The medullary canal dead space, which helps bacterial colonization, is eliminated by the occupied nail and the antibiotic inside the entire canal, which elutes over the weeks in those situations. So a common indication for antibiotic coated nail would be revision of infected long bone fractures after intramedullary nail, or infected non-unions, or osteomyelitis, or when we are fusing the joint following an infection arthroplasty, infected arthroplasty, or arthodesis after infected total knee arthroplasty. However, additional indication can be in primary fractures like those which are contaminated, like a farm contaminated or soil contaminated or oil or roadside, where it is difficult to take out even after serial debridement the infected tissues or the dead tissues at a micro level, like a grade 3 compound wound. In those cases where the risk of infection is very high, or the potential of that compound wound to get infected is very high, in those situations you can use it primarily. Surgical technique, it should always remain the highest priority to perform a thorough surgical debridement. Without a good surgical debridement, just putting a nail with the antibiotic or uh, packing the defect non-union or packing a pus with cement beads is not a solution. We have to take out the previous implant. We have to remove all the dead tissues, the previous internal fixation, eliminate or excise the entire sinus tract, flush with saline or a proper appropriate mixed with antibiotics, flush the cavity, clean the cavity, and perform adequate sampling and use targeted antibiotic therapy. That means whatever organisms you have grown, uh, you have to use a sensitive antibiotic in the cement when you're using antibiotic coated rods, or during the debridement, after the sampling, then after the surgery, you start appropriate IV or oral antibiotics till about 4 to 6 weeks. So antibiotic coated implant should not replace a proper debridement. It should not be a concept that whatever may be the infection, I just put an antibiotic rod and it is going to do a magic. It is going to clear the infection and it will make the cavity sterile. It is never going to be that way. Also, whenever we use an intramedullary nail, and if it gets infected following a chronic infection, the nail forms a biofilm around circumferentially. Not only that, there is a granulation tissue inside the medullary canal, and the endosteum is lined, particularly when you have a chronic infection, by a fibrous membrane, and that needs to be cleaned thoroughly. That all the debris from the canal must come out, and hence a close exchange nailing is not a solution. A close uh, antibiotic rod is never a solution. We have to eliminate the infection from the medullary canal by rigorous scraping of the medullary canal. If you use a flexible reamers, they will rim only the narrowest part of the medullary canal, that is the isthmus. But beyond the isthmus, proximally and distally, there is metaphysis, which is lined by this granulation tissue. So you need long scoops, long curettes, or revision instruments, particularly used in THR, like a long grabbers, long biopsy forceps, to take out all this tissue and then perform a rigorous lavage uh, like this, without opening the non-union site. If you just do that, that is not a good surgery, or that is not a good adequate debridement. So the medullary cavity has to be enlarged with a soft tissue reaming drill, a bone window distally through which the necrosed infected tissue can be washed out by a other channel must be practiced. The medullary cavity is irrigated 2 or 3 times with sterile saline and hydrogen peroxide. Surgical drape gloves are replaced, and bone and soft tissue samples and purulent secretions are collected for pathology, bacterial culture, and drug sensitivity test during the debridement. What was used earlier as instead of a cement rod were K wires or cerclage wires around which beads were made and then implanted. Also, Elizarov wires were used, or ball tip guide wires were used, or Steinman pins, which was called as antibiotic sticks, were used earlier. And these were the first generation antibiotic implants which were used. The second generation were more stable constructs and allowed simultaneous weight bearing were used, and these were in the forms of intramedullary nails, which was propagated either antegrade or retrograde for femur and tibia, where the second generation nail. And very often these are fabricated on the operation table. The one which are commercially available are very expensive and not readily available. What type of antibiotic in bone cement? Heat stable antibiotic that provides wide antibacterial coverage. The antibiotic cements which are readily available are the Palacos and the Simplex, where a premix most frequently used antibiotic is a gentamicin. Palacos and Simplex have this. Simplex also comes with a tobramycin antibiotics, where they can be used directly. What quantity? Vancomycin, 2 grams, either alone or in combination of tobramycin, 3.4 grams are usually used. The heat stable antibiotics are gentamicin, teicoplanin, cefuroxime, clindamycin, which is now available as Copal, gentamicin, and clindamycin, with 2 grams of colistin for multi-resistance pseudomonas are usually the antibiotics which are commonly used. The molding technique and the instruments, uh, 40 grams of polymethyl methacrylate cement and 2 grams of antibiotic, vancomycin or other, were mixed. Then the polymer was added. That means to the powder form, we add 2 grams of antibiotics, and then the manual application of the coating on the cement, either a rod or nail, is done, like how you roll uh, for preparing your rotis. So this is a manual rolling technique. I think this slide must be from either Dr. Chandak sir or Dr. Gadegone. I don't recollect, but I give them the credit. Or very often in most of the published series, what is commonly used are either straws, tubes which are available, or catheters, but very often the commonest use are the silicone tubes in various diameters, which have been used as a mold to give a smooth covering. Like this is the kunchar nail, which will be coated, and over that, a silicone tube will give a uniform circular diameter to these, which will be a mold, which will be used inside like this. So the cement, the K nail, then the cement coating, and over that a slit uh, silicone tube is used, and then the roll is made. Now, one company is manufacturing this antibiotic coated nail, and they have also designed a special nail which has a slot in which, in this area, which is marked red, you can add a coating of a cement, and usually that is about 2 millimeter. And this is the die which they give along with it. Now, you have to line the die, the center of the die, the slot inside on both the side with the cement, and then like this, and then put your cement, put your nail inside the die, and then close the male and female like this, so that when the cement solidifies, you have an antibiotic coated nail like this, which has the 2 proximal and 2 distal hole. This is for the femur. And before you finalize, if you use that nail or if you have used a handmade or custom made, see that the nail cannulation before cement is set, like at the locking holes, and the nail before cement, like before it solidifies, the interlocking holes and the distal tip are filled in advance, either with a bone wax or a wire, or simple your cut gloves, so that they are available for locking once the cement solidifies or once you insert them in the femur or tibial canal. So this is how the antibiotic coated nail is ready now for insertion, and it has to be inserted like any normal nail. The rimming of the intramedullary canal should be at least 1 millimeter larger than the diameter of the cement coated nail, to avoid separation between the cement and the nail during insertion. Adequately over rim the canal. So sometimes even 1 millimeter will not be enough. Usually 1.5 or 2 millimeter can be done depending on the size of the cavity. But when we are doing antibiotic rod, when you are using antibiotic rod, usually the canals are very, very wide. However, when this doesn't happen, if there is a separation of the cement, it has to be removed completely from the medullary canal. And again, you do the same. You use a new coating of the nail, use a new cement, coat the nail and again do it. Elution of the antibiotic locally. It is eluted in a biphasic manner within with a initial peak, which is in first hours, the elution from the implant surface, followed by ongoing slow release that slowly decreases in magnitude over the course of the weeks to months, release of antibiotics via the cracks and the voids in the cement. So the elution of the cement starts immediately, and after 3 weeks, it weans off. Very little is coming out after 3 weeks, and practically at 6 weeks, you hardly see any elution of the cement. So that means it has no role after 6 weeks. Situation after the insertion, that is at 4 to 6 weeks. If there are 2, 3 possibilities which can occur after 6 weeks, if the infected bone defect or the infected non-union has been converted to a defect without infection, then like exchange the nail without antibiotic coating or bone grafting can be performed, like what Dr. Chandak sir has shown that case. If there is no infection 4 to 6 weeks and union, the antibiotic nail can be left permanently. If you are seeing a callus, if you are seeing some union, and if you are sure there is no infection and you have treated that non-union with good antibiotic, then the nail can be left permanently provided it is stable to give a stability. Third situation, if the bone infection and the non-union persist, then another antibiotic cement coated nail can be exchanged in that situation. And again, repeat the procedure after 6 weeks. Again, you may have two options out of this, where you see the healing, or if you see an infection with non-union, and accordingly you take a decision. So this is, I think, Doctor, the same case which he has shown, where Dr. Chandak sir has shown here. Now, when you're using a cement spacer or the remaining cement, which is remaining once you have coated the nail, you can use them at the non-union site. And whenever you're using them in the defect, see to it that it overhangs the non-union proximally and distally. And whatever is remaining, you use them as small beads or different sizes and put them around. Don't throw them, so that they can also be used for illusion. This is Dr. Chandak's case, which he has shared me when I had presented. So situation 1, where the infection was controlled, and now at 6 weeks, we removed the nail, and then it was exchanged to a thicker nail, which had a good stability along with bone graft. Here is a case, 53-year-old, infected non-union, 1 year, had a shortening, osteoporosis, and loosening. Here, the antibiotic cement rod was used, and once the infection was under control, then there were no signs of infection. The ESR, the CRP, which was monitored, and the culture was negative, then it was converted to nail and a plate combo, and that went on for a healing. So the third situation, this case is from Dr. Gadegone, where it was a high velocity injury, no associated injury. He had compound wounds proximally and distally, and here a thin short nail was used uh, to give stability. Additional polar screws were used, and then at 3 months, on and off fever, the nail had loosened out, inability to bear weight, oral antibiotic post surgeries were continued. So here, this infected non-union was removed, debrided, and renailed, where a thick antibiotic rod was used in this situation. It was snugly fitting, it was locked proximally and distally, and at 6 weeks, uh, the there was enough evidence radiologically that there is a callus formation. Hence, the nail was written by Dr. Gadegone. Remember, the antibiotic concentration is highest when you use a cement at the non-union infected non-union site, and that goes when you're using a cement spacer, it goes to the extent of 200 times greater than what your systemic drugs can elute at the infected non-union site. And at 6 months, it completely healed. So the antibiotic rod was never removed. And this is at 2 years performing all the activity. So there is a role, there is a evidence where in those situations where the antibiotic rod can be retained till you get the union, and provided it is stable enough. Rehabilitation and antibiotic regime. According to the drug sensitivity, a sensitive antibiotic intravenously should be given for 2 weeks, and then oral antibiotics for 4 weeks. And after the wound has healed, functional exercises of affected limb joint and gradual partial weight bearing and training under a protection of brace should be allowed. The complications, they range from 5 to 30% in the literature, and commonest is debonding of the antibiotic cement during the removal of custom-made implant. Others were persistent of infection or a non-union. And lastly, hypersensitivity and allergic reaction to the antibiotic. Cement retention, which is a complication known while you're removing the antibiotic nail. The cement debonding was reported in almost 21% with infected non-union treated with antibiotic coated rod. Retention of biofilm containing infected cement residues can be considered as a nidus for reinfection. Hence, every attempt must be made to remove the nidus of infection, that is the retained cement. So unless you remove that, you should not use cement again if you're doing it for exchange. Cement fragments removal with a J hook or with sequential reaming or subsequent copious irrigation of the canal using canal tip, pulse lavage or a distal vent should be practiced. There are also long biopsy forces, which are forceps, curved ones, which are usually used for revision THRs to remove the retained cement, can be used in the femoral or tibial canals. Timing of the nail removal at 4 to 6 weeks, which correspond to the time frame for a favorable antibiotic elution, would be the ideal time, or infection control is achieved, or exchange with conventional intramedullary nail is indicated. That is a timing for your nail removal. Antibiotic coated nail, in conclusion, high local antibiotic concentration can be achieved without increasing the systemic levels. Adverse effects are rare, and it can be a valuable adjunct in the treatment of infected fracture and non-unions, and might be worth considering in initial treatment for open fractures which have a higher risk of infection. Control of infection and the success is almost 90 to 95% with antibiotic nail. Less cumbersome, safer than external fixation. It provides superior rotational and length stability because uh, we are able to lock proximally and distally, and because of the cement coating, the size of the nail is quite thick, which gives a good axial and lens stability and better weight bearing ability. Antibiotic coated nail for treatment of infected non-unions for TB and femur were systematically reviewed. 22 articles, 506 cases were identified, and the overall infection irradiation was almost 90%. It ranged from 68 to 100%, and the bone consolidation rate was almost 86%. So what is the future? Number of newer materials for antimicrobial coating of orthopedic implants are under development, which includes polymer lipid encapsulation matrix, DAC, that is Novogen, or silver ion doped ceramic nanopowder and anodization with iodine. And that is the nail, expert TBL nail, the Protect nail, which was available in India for some time, which had that cement coating, which had come about 10 years back, but it is no longer readily available in the market. So that was about the antibiotic coated nails.
Start the video. Yeah. Any burning question to Dr. Sangeet Gawhale? Otherwise, we'll go with the next talk because it's again a similar talk.
So if we retain the antibiotic coated nail, won't it promote infection again? Won't it act as a foreign body and promote infection?
So, see, we are monitoring that patient. It is not that you are forgetting. There will be local signs, or radiologically, you will see a different callus, or patient will be symptomatic, and you are monitoring them with blood markers like CRP and ESR. So, if it is progressing to non-infected non-union again, if these are not like clinical picture and the blood parameters, if they are not suitable, and your x-rays, if they are not matching, then it is a foreign body. A cement nail is a foreign body which has to be removed. Am I clear to you?
Yes, sir. No, sir. After you told that after union, you can retain the nail, the antibiotic cemented nail permanently.
That is not
provided
retained permanently. Yeah, it can be retained till the union
that
happens
means,
if it is uniting.
Yeah. So at 2 years, you can consider it removing it. Consider removing it, provided he doesn't have any local signs.
Okay,
Once
sir.
you have ensured it has united, you can remove it at a later date.
Okay, sir.
Good evening, Dr. Mutha, sir. Dr. Satish Mutha has joined.
Good evening.
And we have a pleasure.
So I was here only. I was listening to
of,
Okay.
your company.
Okay, I think I'll go ahead with my next talk.
May I, sir?
Yes, please.
Sir, recently we have done infected non-union of femur. So in that case, distal femur, that was a distal femur. So in that case, we have to find 6 surgeries before. So in that case, we have to remove the distal part of the femur that we felt it is non-vital. So what is the particular sign till how we have to remove the bone, or after only removing the soft tissue, and if the bone is intact, so can we retain the bone, or we have to remove out that the part of the bone? Because after removing the bone, we had a large window, large circumferential part we have to remove.
Yeah, that you can treat
And
with
that previous surgeon, previous surgeon had put the fibula inside the medullary also, and we tried to remove that fibula, but completely we could not take out. That was stuck.
So, Rahul, you have to remove all ivory white bone which is not bleeding on fine chiseling. So, if you don't find paprika sign, you have to remove a dead bone. However, a critical zone of bone at times can be preserved with good antibiotic elution. It can happen occasionally, but usual dictum is to remove whatever is dead, necrotic, ivory white.
Yeah.
Okay. See, now you can reconstruct bone by many means they are available. So reconstruction, you can take either the masculine technique or you can use a bone transport. There are many, many ways to reconstruct bone. Okay.
But sir, at that time, the posterior middle part of the bone has a soft tissue attachment.
So
So
partial removal is an excellent option. Many times this happens commonly in forearm bones, that the part which is away from surgeon, so that escapes the brunt of surgeon's denuding of periosteum. This is what is common. So part which is near the surgeon usually becomes necrotic because that part has been played upon. The part which is away from the surgeon usually is vital. Then you can retain that bone. It helps in many ways. One, the length of construct becomes lesser. Number two, that also helps in making it more stable so that you can keep, no problem. So you can remove partially, or you can also remove something like which happens in lamination in the cuff tears. So you can remove the lamination of bone also.
okay.
Yeah.
Sir, any video demonstrating the custom-made interlocking cemented nail, coated nail?
Yeah, they are there. We'll share you.
Okay, sir.
Okay. Thank you, Sangeet. Thank you, Rajendra, for that wonderful talk. I'll go ahead with a similar talk. This will be about the primary interlocking nailing. So, we all have seen, when you are a nailer, definitely you will all have seen infected nailing also. How we were managing earlier. A infected nailing, we removed the nail and fixed that with a elitho fixator, and the patient was on the fixator almost about 1.5 years and it united. Another case, a compound fracture, initial nailing was done, unfortunately had a bad infection and we had to remove the nail and put a L0 and remove all the necrotic bone pieces at the fracture site, and he had 7 centimeters of shortening, and luckily the fracture united and the infection got totally controlled. So then as a second procedure we lengthened proximally and got that 7 centimeters in over 7 months time, and this is 15 years follow up. Recently the patient had come with an excellent united fracture with the excellent function of the ankle as well as knee. Another infected D nail, the case again we are treated in a similar fashion. We docked after freshening the ends and also started the lengthening immediately, and again this took almost about 18 months and the patient had a good outcome with this Elizero. Then came two-stage antibiotic coated nail. So in the late 90s, Dr. G.S. Kulkarni popularized in India antibiotic coated nail. Initially we were doing over the wire, then we started using L wires and K wires and Steinman pin, as Dr. Sangeet Gawhale was telling. In the late 90s I have used all of them. I'll share some pictures later on because they are not in this presentation. So infected fracture like this, we removed the ivory white bone piece and added a antibiotic coated nail. V nail was used in this case, and that was the bone piece I have removed sometime in 2001. I have done this case, and after 6 weeks we removed that antibiotic coated V nail and did an interlocking nail, and this at around 3.5 years time. He had a stiff ankle but a reasonably good knee function at the end of the surgery with the fully controlled infection. My own case, I had operated a femur, close nailing was done, but the patient had bad abrasions which got infected, and the patient was toxic. So I exchanged that with an antibiotic coated canal initially. That's on 3rd of March 2007. I have done this surgery, and the patient comes only on 7th of July, 4 months. Though I had said that interlocking exchange has to be done at 6 weeks to time, the patient came only at 4 months time, and luckily the infection was all cleared by the time. So I extracted that infected earlier antibiotic coated canal and did a interlocking nailing, and the fracture got consolidated in about 1 year's time, and this is after the implants have been removed. So even while doing implant removal also, as there was a distal screw, you can see was loose because of the infection. I reamed the whole canal again, as Dr. Chandak was telling. We injected saline mixed with hydrogen peroxide and did the from the distal whole site, all the dead necrotic material came, and luckily the whole infection got cured. Problems I have faced in antibiotic coated nails is our patients may not come in time at 6 to 8 weeks for exchange nailing or the second stage surgery. Socioeconomically reason, they refuse two surgeries. They don't know what is ABC of this infection, how to manage. If I tell that I have to do two surgeries, they think that it is not the way to be treated. They don't come only for the surgery. Cement retaining inside, debonding of the cement and difficulty to remove. As you have heard in the earlier talk, almost 21% of the cases cement gets retained. So that is another problem. Inability to remove cemented rods. Sometimes the patient comes so late that it is really difficult. It has already got bonded with the bone and it is really difficult to take that out. These are some of the things I have faced, and hence as a innovative idea, I started using primary interlocking antibiotic coated nails. I have used it in delayed union, then the non-unions, infected non-unions, then compound fractures which are coming late to us. So these are some of the cases. Recently, this patient I operated during COVID time. This simple fracture shaft femur was treated on the same day. The surgeon was in a hurry to treat that patient, otherwise the patient will go to somebody else. So he treated immediately with the interlocking nailing. Unfortunately, that got infected. The patient had pain at the distal interlocking site. The distal interlocking bolt was removed. Then the second distal interlocking bolt broke, that was also removed. Then there was an instability. The infection got extended to the whole of the middle canal, and patient had to undergo 3-4 debridements and abscess drainage. Finally, eighth surgery was done in the form of external fixator application, and after 3 months time, once the fracture seemed united, the patient was put on a plaster for a month's time, and dynamization started after fixator, and the plaster was removed. Plaster was applied after fixator removal, and sometime in March 21, that is exactly uh, 11 months after the first surgery, after 9 surgeries, the patient uh, was left without any external support. Unfortunately, exactly after 1 month, when he was trying to wear pant, he noticed that there was abnormal mobility. This time he went to another surgeon. That surgeon decided to do plating. So he obtained bone grafting. This is the wound of the bone grafting with a drain there. And he opened the fracture site. When he opened the fracture site, there was pus. So as there was pus at the fracture site, he just packed that and kept like that. And the patient came to me in this position. This picture I have taken myself in my hospital on my X-ray table. So this is how the patient came to me. Already bone grafting has been done, obtained, but no graft was with the patient, and the wound was open, just packed in this fashion. So what I did was I applied vac immediately. Then after 3 days, I took the patient. The patient is literally financially exhausted after 10 surgeries he has already undergone. If I again say that I have to do 2 surgeries, they run away. So I decided to do a interlocking antibiotic coated nailing. So this is I just applied the vac for 2 days and the wound became little shrunk in size. Then on table one of the broken piece which was still retained inside. That's a nidus for infection. So you have to remove all metals, everything from the middle canal. So I reamed the canal with a disc punch. I grabbed that bone, broken piece of the bolt, and I took that out. And once I did that, how we prepare antibiotic coated nail. So these are straight nails. These are serrated nails, and there is a small stub at the tip. So this tip is 9 millimeter and this is 7 millimeter, or the tip is 11 millimeter, this is 9 millimeter. So the rod is 2 millimeter smaller than the tip size. So debonding of the cement will not happen. Another thing, it is knurled so that the cement get fixed very well. And normally nowadays I use two antibiotics, one antibiotic for the cement coated nail and another stimulant beads or the calcium sulfate beads with another antibiotic to insert at the fracture site. So I use two antibiotic coated nails. The proximal end of the nail is the proximal most part is 13 millimeter here. The expanded portion is 15 millimeter. So where you keep the proximal end, accordingly the thickness of the nail can be changed. So if I am using a 9 millimeter nail, the distal most part is 11 millimeter. The bulb here, the expanded portion of the nail is 11 millimeter. So uniformly 11 millimeter cement can be obtained. If I keep this part of the nail on the table, the proximal end will be slightly conical and it becomes thicker. So this is how we prepare the antibiotic coated nail, and we make the holes in the interlocking nail. There is a jig to do proximal locking, and distal locking is done by freehand technique. The advantage of this primary antibiotic coated interlocking nail is antibiotic leaching helps to control infection. You have already seen that 200 to 300 times more than what you can achieve by giving intravenous. It's not that it is a small amount. Even if the organism is resistant to the whatever the antibiotic I have used, the chemical nature of the antibiotic is so much that it will kill the bacteria. So in that concentration of the antibiotic, none of the bacteria can grow. That's the reason why all this antibiotic coated nail gives excellent results. Interlocking helps to give better stability, and you can allow patient to walk, and it is economical to the patient because both the surgeries are done in one sitting. That is, first stage surgery and the second stage surgery is done in one sitting. So it's economical to the patient. So this is the advantage of this primary antibiotic coated nail. Normally, if I reamed up to 13 millimeter, I try to put a 13 millimeter nail only. If I am unable to put the 13 millimeter nail, I ream it to 13.5 and again put this. So the reason is the contact between the antibiotic surface and the internal surface of the bone is also very, very important. If your antibiotic coated nail is loose, then you will not be able to control the infection. Internal gripping, making the working length shorter, is very, very important. So try to use the thickest nail that can be accommodated. See, I am rotating this. In spite of that, debonding doesn't happen. The reason is the good machine which nulls the surface of the nail so that cement gets fixed to the nail very well. So coming back to this patient. So I did the antibiotic coated interlocking nail. You can see a uniform, you can see in this picture, middle picture of the X-ray, uniform antibiotic cement. Because of the stub of the tip of the nail, uniformly it is there all around. So the patient was made to walk. This is just at the second post-operative day when the dressing was done. This is 2 months post-operative picture. At 2 months, he was walking unsupported. Because we have freshened the ends, there is about half an inch of shortening. That's why there is a limp in that patient. But he had a good outcome with excellent infection control, and subsequently the fracture also healed. This is a 4 months old X-ray which shows good amount of callus in this patient. This is at 1 year. You can see beautifully the fracture is healed and consolidated, and the function at 1 year healed. This is on the day of implant removal. This video I am showing implant removal. This is unedited video. You can see that the whole cement comes out without any debonding. This is only because of the tip of the nail which I made little larger. Because the tip of the nail has been made slightly larger, the bone cement will not get retained or cement will not slip off the nail. So that is the advantage of this. So this is after the implants have been removed. So this is the bulbous portion of the distal part of the nail which prevents debonding of the cement, and also this helps in achieving uniform cement coating on both the sides. So the gap when you keep it on a table is equal on either side. There is 1 millimeter gap on either side. So 1 millimeter of cement will get attached uniformly. This is a young boy of 11 years treated with a V nail. Unfortunately, it got infected. He got the first surgery done. As the nail was loose, as the antibiotic coated L wire was loose, infection could not be controlled. And second surgery was done with another antibiotic. Unfortunately, that also didn't help because the antibiotic nail was loose in the canal. That was the time he came to me for the third time, and this L rod was rocking in and out. He could push it whenever it used to come out. He used to push it in by his hand. It was so loose inside. And what I did was the ivory bone, the dead bone piece I removed. You can see I inserted an antibiotic coated K nail. That was the time I was using antibiotic coated nails still, and also added an antibiotic wire there. It fracture got healed. Unfortunately, patient has never come for implant removal. Even now, after 15 years, he has not come to me. So this is at 3.5 years. You can see the fracture has united, but the antibiotic coated nail is still inside. This is the problem I face with my patients. They don't come for implant removal. They don't come for exchange nailing in time. They refuse to get two surgeries done. That is the reason why I designed this interlocking nail. Another patient, not operated by me, but an antibiotic coated nail was done. And after about 4 years, he went to the another place, and that surgeon asked to get it removed. While trying to remove it, the proximal end got infected. The wound over the proximal hip got infected. As they were not having proper instrument to remove, they probably used unsterile instrument to pull it out, and none of them worked. And unfortunately, the proximal end wound got infected. He went back to the earlier surgeon. He tried second time. He also was unable to remove it. Then the patient was referred to me. That was the time I was confirmed that the eye of the canal was intact, and I have designed a heavy duty extractor. One side the canal hook sits, and other side it gets attached to the interlocking extraction set. So with this heavy hammer, I could extract the nail. You can see debonding of the cement. A part of the cement, the proximal part of the nail came, and the distal part cement got retained inside, which I had to use reamers, then curates and other things to take it out. So this is that Solapur adapter, one of my innovations. So where a heavy duty extractor, canal extractor, with that I have successfully removed lot of old canals and denails being done. This patient uh, comes to me quite regularly and brings complicated cases still uh, uh, for treatment by me. So sometime in 2005, myself and Dr. Pradeep Kotadia, we were operating together one case, and the cement we were unable to remove it, and that's when we decided to start a antibiotic coated primary interlocking nail having a small bulb at the tip. This nail was designed in 2005. This is the first generation in primary interlocking, primary antibiotic coated interlocking nail, where this roughening of the surface was done by using a hammer and chisel. Somebody used to sit and hammer over that and make rough surface. This is one of my earlier case where we have used this fracture pelvis with a bad wound on the thigh, with a compound fracture of the patella, compound fracture of the leg, and so many other things. The patient came almost after 3 weeks after the initial injury, and that time we used this nail. Again, you can see the thick proximal distal end of the nail, and antibiotic, primary antibiotic coated interlocking nail we did. We had to open the fracture because already there was a infection there, and we used this antibiotic coated nail. And this is 2 months picture. We also operated his pelvis, leg and other parts that I am not showing, but the fracture healed in due course of time. This you can see the compound fracture of the thigh healed within about 2 months time. This is 2 months follow-up, and this is at around 7 months follow-up. Unfortunately, I lost subsequent pictures due to a virus sometime. So this is the last picture I have got. This is the first generation in primary antibiotic coated interlocking nailing, and where the serrations were done by hand. Then machines did this horizontal serrations round all around. This is the second generation nail we designed sometime in 2009, and this one more compound fracture coming after 3 weeks after the initial. You can see already the new bone is trying to form. The patient was in a government hospital, came after 3 weeks to us, and again we did the interlocking nailing. And this is 3 months follow up, and this is 7 months follow up, and this is after the fracture has healed. So this is the second generation nail. The third generation nail is CNC machine does the knurling now. Earlier first generation was done by hand. Second generation with a machine we used to do only horizontal knurling, but now crisscross knurling is done, which helps in bonding of the cement very well to the nail. So this is the one which I've been using for the last almost 12 years. This fracture TBI was operated. This fracture TBI was operated multiple time already. Even he had a venous injury and arterial injury which was grafted. Then skin flap was done. Unfortunately, the fracture didn't unite, and you can see the contact is very important. So that's why the proximal end I have made the antibiotic coated nail almost 15 millimeter, because proximally the middle canal was very wide. 17 millimeter was the proximal canal. So I made a very large proximal end. Yes, definitely when you make a large hole, your entry also hole also becomes larger. But for the infection to get controlled, I had to use this large size nail. You can see the beautiful, the nail is snugly holding at the fracture site, and the fracture got cured in due course of time. And this is the final picture. You can see that there is already flap has been done, very bad wound, but at least we could successfully get the fracture united. Coming to the preparation of the antibiotic nail. Earlier, what we were doing is we were using K nails or nails, and we used to take a flat surface and we used to pin roll them and make a more or less uniform round, and we used to pass them through the ACL gauge or the ACL gauge or the K nail gauge, and confirm the thickness. So, and whatever the cement is extra, we used to use them on a wire and make a chain and keep it ready. Then we started using antibiotic nail over a chest tube. So we used to put the antibiotic coated nail inside the chest tube and apply the cement. But the disadvantage is this: you can see the nail can be seen. This antibiotic coating on one side is more and other side is less. So that is the reason why I designed this nail with a small stub distally. Because there is a small stub distally, when we keep on the table like this, there is uniform cement application all over the nail. So if it is 1.1 millimeter, it's all over 1 millimeter. If it's 2 millimeters, it's all over 2 millimeters. Uniformly, you can uh, apply the cement in this patient. So this is the last case I am showing. This mentally retarded person had a fractured shaft femur which was nailed way back in 2018. And in 2024, he started getting swelling in the thigh. And there was multiple loculations which had 40 to 400 ml of different collections, and the pus sensitivity came as sterile. A general surgeon operated this patient. He drained this and sent for culture sensitivity, and it came as sterile. So that was the time the patient again had recollection. Then he approached the orthopedic surgeon. again the same amount of collection, 400 to 450 ml of collection, and this was the nail which was there earlier inside, and the ultrasonography report showing that 153 ml to 402 ml of collection at multiple places. When we opened the fracture, we saw this yellowish material like this. So we knew that it is, as the report had come sterile, we knew that it is probably fungal. So we didn't go ahead with doing anything at this stage. And you can see that the nail was also loose. Nail was also loose. We just cleaned the whole medullary canal and applied the patient on a skeletal traction and kept him like this till we got the report of the culture sensitivity. The culture sensitivity report came as expected, Candida albicans fungal infection, which was sensitive only to voriconazole. Luckily, voriconazole is a thermostable antibiotic. So we plan to do a anti-fungal antibiotic coated combo nail, that is nail plate combination. The nail was prepared, the plate was also prepared, and we have applied this nail plate combination in this patient. And this is 5 months post-operative. The fracture is healing quite satisfactorily. This is 8 months post-operative with good function. As I said, this child, this is not child now, it is an adult, 25 years old person, is mentally challenged, but he is able to walk without any uh, support. And we have not removed the implant as of now, but we plan to remove in stages. We don't want to remove both of them together. We'll remove the plate first and then we'll do the nail. Friends, this is all about the Solapur nail, or the primary antibiotic coated interlocking nail. First generation nail designed in 2005-6, second generation nail designed in 2007, and the third generation nail done by CNC machine, which has been designed in 2012. So as you all know, the advantage is antibiotic leaching helps to control the infection. Interlocking helps to get better stability. It is economical to the patient as we are doing two surgeries in one setting. Thank you very much. Now I'll stop sharing. If any question you have related to interlocking, nailing, or infection, you can ask immediately. Otherwise, we'll go ahead with the last talk, because majority of the questions have been answered quite well in the first talk itself. If anybody has got any doubt, yes,
In that last case which you have shown,
yes,
hello. So
yeah, yes,
even
Sangeet.
if yeah, even in the last case which you have shown, even the plate you have coated with the antibiotic
Yeah,
cement,
yes, correct.
right?
Yes, correct.
So that is the additional thing what you can do apart from using an antibiotic coated nail.
Yes, yes.
But
Actually,
what's
this I
the
learned from Rajendra Chandak only. I saw one of his case, he had used a plate with antibiotic coated. So that,
Sir, what about the infections regarding the smaller bones in the
so
forearm?
we have to just apply the cement over the plate.
yeah, I think smaller bones still questionable, but forearm we have used, and usually forearm extreme fixator just and other things helps quite a lot. And one or two cases we have used smaller L rods or a antibiotic coated plate we have used. Wherever the soft tissue cover is good, infection, getting the infection controlled is not much problem. The problem comes in tibia, subcutaneous bone, where the soft tissue cover is poor.
If the time permits, I'll present after Gadegone sir's lecture.
Yeah,
I have
Uh,
few slides on infected forearm.
Secondly, sir,
yeah.
if if we have done everything and after insertion of antibiotic beads along with the antibiotic nail, what is your advice regarding application of vac machine, sir?
See, as far as possible, you should not apply vac machine, because whatever the leaching of the antibiotic is happening, that will
Will be
come
drained
out.
out by the machine.
Yeah.
Yeah,
So
yeah.
if you want to really close the gap immediately, yes, you can use it for few hours or few days, 1 or 2 days, because the antibiotic leaching still happens significantly for about 7 days to 2 weeks time. So initially, if there is no other option, you try to use vac. Yeah. Yes, Rajendra.
Yeah, there are 2 or 3 good inputs if you want to use it for any reason. You want to use negative pressure wound therapy. Number one is use CINPWET, that is closed incision negative pressure wound therapy. Number two, you can use it in intermittent mode. So you can give vac suction for 1 minute and 9 minutes is without suction. So that mode you can use. Number three, put the bead or the cement etc. in the deeper intramuscular plane and apply vac in only in the subcutaneous plane. So whatever leaching is happening with the negative pressure wound therapy, it is coming out through the infected tissue. So in all these three methods, we have used it and has been effective.
Yeah.
And regarding the soft tissue closure, sir,
Mhm.
after infection debridement, you have put everything. Do you use Vicryl or you take the directly skin sutures?
In different situations, different things. Anytime, whenever you close after infection control, if there is tissue tension, go for tissue transfer. If there is no tissue tension, use only subcutaneous Vicryl. Don't put at all ethylone or any other suture. The reason is two. Multiple bites onto the skin itself leads to propagation of infection and also bacterial adherence at those sides. So only subcutaneous Vicryl, that too Vicryl that is coated with triclosan. So that is a good practice and has given me good result.
You don't close the skin in that
Not at all.
situation.
Not at all. So
And
just
but sir,
and
sir
it's both
regarding the
subcutaneous.
Vicryl, it's a braided suture, no sir?
The
Theoretically,
Vicryl,
the bedded suture should be
Yeah.
in
so,
contraindicated.
so use Vicryl with triclosan. That is Vicryl plus.
Vicryl plus. Yeah.
Right. Triclosan is a very good antibacterial. One beauty of triclosan is it has still no bacterial resistance.
Yeah.
Okay.
Vicryl plus.
Yeah.
Yes,
Vicryl plus.
that you can use.
Thank you, sir.
Okay. Gadegone sir, please go ahead with your presentation on arthrodesis nail.
Still time is there or?
Yeah, till there is time. We are got Rajendra Chandak also having a small talk afterwards. We'll
Okay.
finish that infection part today.
Yeah.
Okay.
Yeah.
Share. कहाँ गया share वाला?
इसमें से क्या क्या शेयर करोगे सर? There are so many things to share.
Yeah.
Yes, we can see.
सब दिख रहा है?
Yeah, yes,
Yes, fine. Go ahead.
So
Yes,
this
sir.
is something. It is not a. It is a very old practice, but I want to just present because everybody should know, the younger generation, that 20 years, 13 years ago, something was being done for the bone gap after excision of the knee joint. So for benign tumors treated consisted of simple curettage. However, subsequent recurrence rates were more than 50%. Extended curettage reduced the recurrence rate because of use of power bar, phenol, liquid nitrogen, cement and other methods reduce recurrence. For aggressive tumor nowadays, wide resection may be recommended treatment to prevent recurrence. But in the modern era, the use of allografts and megaprosthesis have become the method of choice after bone tumor resection at the knee joint or any gap after excision of the joint. So treatment after resection endoprosthesis provides immediate stability, mobility to the joint, but it is costly and of limited longevity. Imported modular endoprosthesis for the knee cost about more than 3 lakhs, and high quality ingenious implants are not yet available at the affordable prices. Allografts are not easily available. So modern facilities or expertise may not be readily available. The surgeon has to rely on other technique of treatment such as non-vascularized fibular stud graft, cancellous bone grafting, and a turnoplasty after excision of the tumor. So the aim of presentation is to identify the effectiveness of en bloc resection and biological reconstruction by autograft in tumor around the knee joint. Arthodesis provides a reliable means of treating such condition. So there are two methods which I use it. Two fibular stud grafting or femoral tibial turnoplasty. So that if you can see here, two grafts of fibula are kept here around the nail and supplement with corticocancellous graft. And other method is the half of the upper tibia or femur is split into two parts and turned around it along with the pedicle of that vascularized pedicle to the other bone, and that is known as a turnoplasty. Adjoint IM nail or plate plus corticocancellous graft. So how to use it? After wide resection, two struts were fashioned from the harvested fibula. Fibulae inserted into the medullary canal at the resected area of the tibia and femur. Knee was orthodized in 10 to 15 degree of flexion. The limb is kept 1 centimeter short to clear the ground and plate or intramedullary nail rod fixation. This is an aggressive distal femoral fracture, distal femoral tumor. Resection arthrodesis was planned. You can see here how everything was gone. And then strut fibular grafting. Knee arthrodesis is planned in 5 to 10 degrees of flexion and 1 centimeter short intramedullary rod fixation. Cancer bone graft were placed transversely along the entire strut and circumferentially over the house junction bone. And then this is an example I will quote. A Versa 20 years old female, distal femoral giant cell tumor, treated by curettage and cement implantation, presented with a large swelling around knee and inability to walk after 3 years. Biopsy aggressive giant cell tumor recurrence, and therefore the decision of excision of the lesion was planned. Resection, en masse resection is done of the distal femur, you can see here. And then two struts were fashioned from the harvested fibula, inserted into the medullary canal at the resected ends of the tibia and femur with the IM nail. So this is an IM nail with 10-degree bend here at the knee joint and two fibulae along with the corticocancellous graft. And then 2 years follow-up, 3 years follow-up, 5 years follow-up. There is a complete incorporation of the fibula into the parent gap and corticocancellous graft incorporation. 5 years follow-up, now it's more than 10 years follow-up. Patient is walking and doing all activities of the daily living. And you can see the same patient, more than 15 years of follow-up. And when I did the operation, she was not married. And you can see the daughter of that lady. And you can see the hypertrophy of the bone and incorporation of the two fibulae taking the shape of the parent bone. Another example, aggressive tumor, giant cell tumor, en masse resection of the tumor. Two struts were fashioned from the harvested fibulae inserted into the medullary canal at the resected ends of the tibia and femur with IM nail. Complete incorporation of the fibular graft, 1 year follow-up, 3 years of follow-up, and you can see a 5 years of follow-up, complete incorporation and hypertrophy of the fibular graft. Another example, a giant cell tumor in a 30-year-old lady after curettage and cement with distal femoral fracture. And you can see here, this was fixed with the this plate plus adjoint bone grafting. And then again, The patient, you can see here, cementing was done for the giant cell tumor. And then you can see there is a recurrence of the tumor after a curettage and bone grafting and cement implantation after 3 years. So I planned resection, arthrodesis, fibula plus corticocancellous graft at the resected end at the tibia and femur, and with the IM nail, and you can see here 2 tubuli were fashioned like this, and then some slices are taken from the femur, and then more than 10 years of follow-up. She is now working lady, complete incorporation with hypertrophy of the tubular graft and taking the shape of the tibia. She is from Uttar Pradesh and doing well, and more than now 15 years follow. Another example of an aggressive tumor of a chondrosarcoma, same treatment was given, complete excision and resection of the arthrodesis, and you can see here, there was a fracture of the bone, and the fracture of the nail, and the patient did not come, but the fracture again united, 9 years of follow-up, died of pulmonary embolism metastasis in 2007 after 18 years of a index surgery. So turnoplasty, excision of the tumor in the upper end of the tibia, required length of the lower end of the femur split into 2 halves, and one half of it turned upside down and fixed over the left out stump. Cancellous bone graft were placed transversely along the struts and circumferentially over the host junction. IM nail are plate, and this is an example. A 56-year male with a involvement of the articular surface. After en bloc excision, reconstruction is done, and a turnoplasty technique of arthrodesis, half of the femur is turned down to and attached to the fibula remaining. Patient is on his leg, 10 years of follow-up. You can see there is a complete incorporation of the bone. Nail is still inside. Recently, he visited me for some different work, and you can see here how the patient is walking. There is no problem. Functional outcome after pain. किती दूर चालू शकता तुम्ही? चालू शकता? पायावर करा, खाली करा, वर करा. So another example, aggressive joint tumor, 46-year-old male. After an en bloc excision, reconstruction is done by a turnoplasty technique of arthrodesis. 1 year follow-up, 3 years follow-up. After 5 years of follow-up, he got a breakage of the nail. He came again with the pain. You can see there was a consolidation. And then ultimately I did a renailing. After removal of this, renailing and a plate fixation, and ultimately everything healed up and patient is walking. Another example, aggressive tumor, turnoplasty, resection arthrodesis using autograft, screw fixation and X-ray. This is the half of the femur is transferred to the tibia, complete anatomical amalgamation of both femur and tibia. So he got again fell down from the bicycle, had a fracture in the junctional zone. I did a plating both sides, double plate fixation with bone graft, and then you can see a radiological and functional outcome, everything healed, and patient is still walking. Probably it's a near out more than 15 years of follow. So another example, GCT of a lateral tibial condyle, 32 female, MRI demonstrated extension of lesion to articular surface. Same turnoplasty, fibular graft, corticocancellous graft, and the more than 15 years of follow. Died of coronavirus last year. And then another example, a giant cell tumor, 20-year-old lady, and this was the tumor, lytic lesion in the medial femoral condyle, resection, compression, arthrodesis of the knee, 20 years follow-up. And then when she was 40 years old, she suffered with a fracture at the junctional zone of a distal femur. So I did a close interlock nailing here, revised with nail and graft by creating a tunnel into the narrow femoral canal. And then you can see a 10 years of follow-up. There is a complete solid union between the tibia and femur, and still nail is in situ, and she can walk, she can go anywhere, and you can see this is the 12 years follow-up. She is able to do all activities of daily living. So the average length of the fibula strut is 7 centimeter, the longest being 14 centimeter, and the shortest 5 centimeter long. The average defect length was 8.5 centimeter. Additional fixation, external fixation, plate fixation, and IM nail. Fibular bone grafting, donor site morbidity, moderate gait changes up to 18 months. Calf strength and eversion strength is reduced for some time. Sometime you may get FHL contracture and perineal paresthesia because you are excising more or less a 2/3 fibula from the parent bone. So validity of the locked nail, it gives prolonged support and maintain continuity of the bone. It is one-time method, technically easy, and coverage of the implant is never a problem. Biomechanically, the plate as an implant is inferior to the intramural nail, being some distance away from the line of direct load. Endoprosthesis is most popular nowadays. I don't deny that. And probably what I described may be a old-fashioned surgery, but still it serves the purpose in a poor patient, those who are not affording and not there, the prosthesis is not amenable to them. However, end prosthetic patient have to live a more sedentary life due to feeling of weakness and instability and looseness of the prosthesis is possible. But once the arthrodesis has occurred between the two bones, probably it gives a solid bony construct where the patient can do all activities of daily living except flexion of the knee joint. So approximately 3% of the GCT metastasize to lung. GCT metastasis generally appear an average of 3 to 5 years after the initial diagnosis of primary lesion. However, GCT metastasis may not be detected for 10 years or longer. So follow-up of 13 patients of tumor around knee. In my series, 2 patients had a transient perineal palsy, 2 patients developed infection, refracture in 3 cases, 2 patients died, 1 patient had local recurrence and metastasis, and other case is lost to follow-up. So resection arthrodesis of knee joint was well accepted by our patient. Disadvantage is reconstruction arthrodesis achieves excellent stability, but has a major drawback of lack of knee motions. In conclusion, procedure of resection arthrodesis of the knee using a large autograft with a long intramural nail provides patient with a stable, durable biological reconstruction that allows early weight bearing, and the procedure carries a low incidence of infection. I have some of the cases more than 20 years of follow-up, and they are doing really well without any complaint. So this is my presentation, but I don't want to debate on the recent treatments and more progressive treatment of a giant cell tumor where you get a extended curettage and newer modalities of treatment. I have no objection for endoprosthesis also, but this is the treatment which I have given to the patient, yielded a very excellent result with stable knee joint. Thank you very much.
Thank you, Dr. Gadegone. Excellent cases and so many cases. Uh, Even I might have treated only 3 or 4 cases in my life, but you have treated so many cases and maintained the record also. That's really commendable. I do agree that our patient require different approach because our patients' requirements are entirely different. They are not learned people, and what they want is a stable leg to walk and do the activities which is required, especially in the farm. So I do agree with your line of treatment. Yes, Rajendra, any comments?
No, I think that's an excellent way of managing. Only two questions, sir. How do you manage the nail going to the distal end of tibia? Usually this nail usually went up to the middle third of the tibia, the long orthodesis nail.
We have to do a reaming, and there is a inherent bend in the nail, or you can also bend it near about 10 degrees, so that when reaches to the diaphysis of the tibia, bend comes in the at the junction of the distal end of the femur, and then you can easily hammer the nail inside the medullary cavity.
Rajendra, I have designed that nail for the Yogeshwar implant. This is the femur part is 11 millimeter and the tibia part is 9 millimeter.
Yes.
Instead of the normally the tibial nail will have a slope posteriorly because you are entering from the tibia. But since we are entering from the intramedullary canal, this slope has been given anteriorly so that it will slide against the anterior cortex and will go down. And a small bend is given also to the nail.
I have used two of them.
Okay.
Yeah. I got it from Yogeshwar only.
Yeah.
And they were
A
good.
long time back in the late
Yeah.
90s,
Yeah.
Dr. Rajat Verma, who is now in London, he was using it left and right for community distal femoral fractures. So, so he had shown a lot of good cases, and that's what our patient requires stable leg.
Leg, yes.
So even in a badly communicated distal femoral fracture, you used to put them, and after the gets consolidated, you used to remove them, and few of them got reasonably good results. I have seen many of his cases, and I was used in 2 cases, and unfortunately, I don't have any records of them with me.
Actually, one good indication today would be the defects following has failed, patient had an infection and a bone loss, huge bone loss. So that would be ideal. There's no solution for that.
Yes.
And second is you can combine it with Eliza Rao for a segment transport in which you have a big defect.
Yeah.
So that would be second indication today.
Yes.
And the only problem is since the chance, the nail breakage at the whole side, either distal femur, usually it happens at first or second proximal hole of the tibia. So if we have to remove it after the new fusion, so how do you remove it? Any solution?
It's really difficult to remove because they are also solid now.
Yes.
Because to make it stronger, we have made this nail solid.
Yeah.
Yeah, that's why difficult to remove.
Yeah.
If
You
it
mean
breaks
to
at the
say
fracture site,
to
it's
avoid,
okay. Yeah.
yeah, to avoid breakage, you have made it solid.
Yeah, we have
Right.
made it
Yeah.
solid, and also
Solid.
the interlocking holes in the TBI are not 4.9 millimeter board. It's
Right.
3.9 millimeter board. We have made that interlocking hole also smaller so that the nail doesn't break
Breakage.
that often. Yeah.
Breakage rate is least.
Yeah. Yeah. We are trying to minimize it.
Right. Right.
Anyway, thank you very much, Dr. Gadegone. We'll request Dr. Rajendra Chandak for his talk on forearm fractures and some of the interesting cases.
Yeah. So, able to see this slide?
Yeah, yes.
So this was a patient who had a massive infection after nailing of the ulna and radius. The radius somehow settled down over a period of time. So this presented 1 year after his nailing with florid infection. absolutely in toxic state and massive infection. And this was the extent of infection. So we had to open up the whole forearm. There was suppuration, abscess, everything, and was managed with debridement. And then we put a negative pressure wound therapy for the whole of forearm bone. And this was after infection control, antibiotic elution. So this is, so for forearm, what we can use is a cylinder of cement, and you can, what in our theater we call it as a balan of cement. So the balan has a central medullary wire or K wire. So, or you can use a L wire. So the L wire is put first, and on that the balan central part of the cement is put. That leads to good elution, also good, gives good enough stability to control infection. And these are the successive stages of management. So here what you can see is the antibiotic elution from cement. Negative pressure wound therapy we give occasionally along with that. And this is how the closure at times is. So the wounds are, the skin is actually macerated. So we just put subcutaneous closure and couple of staples if you want, you can give it if it is unstable. And then once the infection is controlled, then we take out bone graft. I usually like to take out bone graft from the inner table of ileum. So half of this we split. So this acts as the forearm bone, and then rest we take out slivers from the bone. And this is how we reconstruct. This is the reconstruction X-ray. So this is the part of ileum which was taken from the crest. And at the end, just too small to keep the footprint of metal small, we can add a plate, but in that case, the patient had no amount of soft tissue available to close the plate. So we did not use plate, only flimsy small K-wire. So this acts like a distraction compression. So you distract just 2 mm more, so it becomes stable by itself, and that patient healed over a period of time. You can see the healing completely. Now he's fit for removal of implant and did well. So this was a severe infection presented 5 months after the plate fixation. And you can see both the plates, both ulna and radius, both are infected. So number one is getting infection control. So we removed the plate. So removal of plate which were infected, then putting the central K-wire and then antibiotic elution. Now you can put the amount of cement what the soft tissue closure allows. So this is the amount of cement we have put because we need good amount of elution. So significant amount of elution of cement. Now what happens if you put beads? Bead is a small eluting material. A spacer of cement, a block of cement is a more eluting substance. Therefore, we put this sort of a balan treatment we call it, and this is how it is. So this is the medullary K-wire. On that we coat the cement, and then on that also we can put a block of cement. This usually take the shape of a triangle. Then you try to close the wound, and the wound is closed just with a subcutaneous vicryl. Once that is done and implant is removed, once the infection beautifully gets controlled in forearm. I don't know why. Tibia takes more time. Femur also you can control better. Forearm has very good
Soft tissue, basically.
soft tissue, yeah. So basically good muscle cover is there. So the infection gets controlled. And once that is controlled, so this is how initially at the time of bone necrosis and everything is there, screws, we remove them, debride thoroughly. The whole tissues are debrided completely. This has to be completely cured. And as Rahul said, at times one of the part of the medullary cavity or the bone can be okay. So the part which is just beneath the plate usually necroses. On the opposite side is a viable bone that you can keep intact. And then that patient was managed with a plate again and bone cement. So this is what replating was. And addition, you can coat this plate with the thin layer of bone cement so that closure is allowed, and you can put adequate graft. You also see a sort of a synostosis, but that was not complete, and that patient healed. So again, the treatment of infected non-union anytime follows two stages. Number one is debridement, elution, closure, good soft tissue. Number two is whatever you want to achieve, stability and healing by bone grafting. And this is how it helped. From one question from a surgeon who said, Can we use negative pressure wound therapy? Yes. This is the way I use vacuum assisted closure mode for most of infected forearm, etc. So a deeper foam is there, completely surrounding the bone. Then a superficial layer of foam is there. This is actually VAC mode. That is vacuum assisted closure mode. So what happens if you keep the whole bed open, then you have to flap it. So in a VAC mode goes on reducing the space of the infected bed. So it is vacuum assisted closure mode. Intermittent sutures you can give. This is another way I like in an acute fracture. So again, we put foam inside. The compound fracture has been debrided completely. This is the classical supracondylar femur. You can finish your internal fixation. You can come out, put few foam slivers in the wound, close with subcutaneous vicryl, and then over on that you put a closed incision negative pressure wound therapy. So here in this patient, there is an antibiotic cement spacer also. Like a red cross. Black cross does a wonderful thing for plastic. So I call it as a black cross. And black cross works wonders for wound control. So this healed completely. So this is how VAC can be used along with antibiotic spacers. Thank you so much, sir, for this opportunity.
So we do the skin closure and above that we apply the vac.
Yeah, so that is known as a wonderful way of CINPWT. There is a good article on that, and I'll share the article with you. This is known as CI, that is closed incision negative pressure wound therapy. So what it does is it removes all the edema fluid. So this is recommended for all complex wound healing scenarios like revision knee or fracture calcaneus where the closure is tight. You can put CINPWT, or you routinely also at times we can use it. There are certain indications. Okay.
Okay, sir.
Yeah.
Thank you very much, Dr. Rajendra. That was a very nice presentation, which you did it in the last minute. I don't think there are any questions. If there are any questions, you can ask them on the WhatsApp group.
So videos demonstrating the preparation of cemented nail.
Yeah, I have shown in my presentation. That should be enough. You want more than that?
You can share it in the group, sir. We can see it also.
Okay. You didn't see when during my presentation how to prepare. I showed. Anyway.
Yes, it's elaborated video, sir.
No, elaborate video I don't think we have. If anybody has got, please post them. Rajendra or Gadegone, sir?
We'll post it, sir. No
Yeah.
problem.
Okay.
Sir,
Thank you very much.
sir,
Yes.
can you also give us an idea about masculine technique? If a video is there, if anybody has any video on masculine technique, especially when you try to remove the spacer and then the membrane and then inserting that, putting bone graft into that space.
If time permits, I will show one or two cases of cement spacer and vascular that masculine membrane and bone grafting.
Thank you, sir.
Today you are showing or next week you are showing? Gadegone, sir?
Yes.
I can show right now also, sir.
Yeah, if you have got ready, then show them. Let's finish the
infection
topic completely in this session. Gadegone is not listening.
I am showing.
You are showing.
चांडक सर दिखा रहे हैं.
Okay, ठीक है.
Just a minute for tracing it.
You can show that case as well as RIA. I think RIA we have shown. No?
Yeah, I think
in the first session we have shown RIA.
Yeah, that was covered last time.
Yeah, I'm just
during the reading, I think that.
Yeah, that's correct.
Now only 1 week is left, I think.
Yes.
Next week we will finish the course, no?
Yeah.
Yeah, I'm just tracing it. Just a minute till that. Any question is there?
Hello.
Yeah, go ahead.
Yes, sir. The display is blanks.
I'm just tracing it out.
Okay, okay.
I'm just tracing it out so that I show the most relevant case. Just onto it. Yeah, I'm just sharing it. Able to see the slides?
Yeah.
Yeah. So we are talking about the masculate technique for sort of long bone defects. So this was a patient had a road traffic accident 6 months back. Initial management was initially I think he had a X-fix and then was shifted to Elizara frame at the first orthopedic facility. And this needed a radical debridement of the fragment because all this was necrotic. And as you see on the X-ray, it looks quite okay. But actually the whole bone was exposed and it has become dry and desiccated. So this is a LRS, a cross leg flap, and antibiotic spacer. Now this is where we have to excel in orthopedics, that you are able to get a, so if you take this case, you may put it as all, let's say, infected non-union or a bone defect, whatever you want to label it at. So for infection control, what we need is good stability, good soft tissue envelope. These two criteria have been fulfilled. Third is a cement spacer which can elute antibiotic. So that also is there, as you can see. So this is the cross leg flap, good stability, antibiotic elution. This is the cement spacer. Can you see this? So this is the cement spacer, and in this patient, once we can remove the LRS, you can put it along with LRS, you can put antibiotic coated nail, whatever it is. You can have elution of antibiotic. Now, once you open that, you give an incision on that. So this is a muscular membrane forms. And once the muscular membrane forms in that patient, this where the graft. You can put in fibula, you can split the fibula into four. That is an art to split fibula into four longitudinally. One of the fibula you can insert in the tibia here and here. Here, of course, I have managed with a rear graft. So these are the rear graft. LRS continues in position, rear graft there, and over a period of a year or more than that, it consolidates completely. Though in the muscular membrane, the medullary cavity does not form easily over a period of at least 3 to 5 years. And then the medullary cavity starts forming. So it takes long time for bony morphology to return to normal. And here you can see the union. This part we should enlarge in the antibiotic cement spacer itself. As Sangeet had pointed out, that this part should be more globular so that that bonding is good. And this is how the patient has healed and is walking. One great advantage as compared to fragment transport is that we don't have to transport the bone, so the equinus is not there. As you can see, he is walking on a straight foot. So this gives good illusion. This gives long bone segment management and also gives us stability. And that is how it is quite stable. Instead of LRS, at times I use extracutaneous plate osteosynthesis. So this was a patient who had a nail. As you can see, everything is infected. Even on X-ray, you can judge infection. So stage 1 with removal of everything and then putting a ECPO, I call it, or supracutaneous plate. So as you put a internal plate, blocking plate, you can put a external plate outside the skin. Only thing is, imaginatively, you have to give incision and give screw purchase. So this is a plate outside. You remove whole dead piece of bone, put good antibiotic eluting cement or stimulant, whatever is your choice. So this is the ECPO, extracutaneous plate, and you can, the biggest advantage is the pin tracts or the screw tracts do not get infected. So if I enlarge this, you can see the skin tract. I hope you are able to see the enlarged version.
Yeah,
Yeah.
beautiful.
So the skin does not get infected. Even one patient is doing his scenic duty at Jodhpur, near Jodhpur, and he is yet to come for removal. It's almost 1 year. He has even joined back duties, and the surgeon there at the unit has told you can get it removed when you go back for your leave. So he's continuing with, of course, some modified duty he must be doing, but he's on. The point telling is he can wear his trousers, he can wear his uniform, he can wear his shoes, and he can go back to his duty also. And that patient with bad infection has completely healed. So that is the advantage. So it gives stability. It gives a locked stability, uh, uh, a stable construct. And therefore, whatever grafts now you are putting as antibiotic, um, after removal of antibiotic spacer, they consolidate better. That is the advantage. So this patient again healed well. So that healed completely nicely. And the tissue healing is also good. The bony healing also proceed as expected. If required, you can additionally stabilize further by putting in more screws or removing screws. This exactly acts like a internal fixator. So this is what I had to present today. And a full masculae, I might send one of the presentation in the group. Okay.
Thank you,
Thank you,
sir.
Rajendra.
Yeah.
Thank you, everybody, because we have everybody to know.
One,
Yeah.
Yes, Rahul.
Yeah, Rahul, you wanted to say something?
sir, one question. Sir, just now I have one patient I have just now, and this is a, I think, 14-year-old boy operated for fracture shaft of femur by the TENS and 8 months back, and the TENS has been removed. The fracture has united, but there is a discharging sinus on the middle side of the thigh. And there I can see a small sequestrum. The fracture is united, but as we can see at the fracture end, this is means to say the medullary canal is not opened, and I think there is a sequestrum that I will remove. But what I should go for that? Either I should open the medullary canal and put the cemented rod, or as the fracture is united, I should remove the sequestrum only and do the
So,
suturization
yeah,
and
got it.
stabilize it.
Got the point. So, osteomyelitis, you will be labeling it. There are 4
Yes.
different varieties of osteomyelitis. Number 1 is exogenous osteomyelitis. Exogenous osteomyelitis at the compound fracture site does not need medullary elution. Osteomyelitis occurring after a infected nail preparation or infected nail etiology needs a antibiotic coated nail. Osteomyelitis after a plate fixation is a localized osteomyelitis. It needs localized elution extra osseous. So what you can do is debride that area, remove that sequestrum and put stimulant. That would be your best bet. So you don't need a second surgery for removal of cement spacer. Okay. And that would work.
Stimulant
I
will
I
Yeah.
think if you
do
post the X-ray, you will
I will
have
post
a
certainly.
uniform, good opinion on that,
Yes.
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 rather than we all imagining what is the
Yeah.
situation.
Right. Right.
Certainly, sir,
Yeah.
I will put. So the stimulant we need not to remove, and that is absorbed, and that is okay.
Yeah, that is the advantage of stimulant. The only drawback is you can't put a large volume, you cannot put in the whole medullary cavity, and you can use only 20 grams maximum. Okay, fine.
Thank you, sir. Thank you very much.
Okay. Thank you very much, Rajendra, Gadegone sir, Sangeet Gawhale, and Satish Mutta. Bye bye. Good
Brother,
night.
we must
Shabakar.
all thank you for providing such a good medium and platform.
Good night.
Thank you.
Good night.
Good night.
Thank you so much, sir.
Thank you. Thank you. Bye bye.
Thank you, sir. Good night.
Thank you, sir.
Thank you.